of the military. A lot of reasons beyond the talk today, but commanders use them as an integral part of the training, and they're recently kind of allude to our soldiers and airmen and sailors as warrior athletes. So when we train them and condition them like athletes. We try to feed them like athletes, and then when they're injured, we try to rehab them and get them back to activity and in military positions as quickly as possible. Our program, we have really three main pillars at West Point. We have a military pillar, we have an academic pillar, and we have a physical pillar. Physical pillar is what I'm mainly going to talk about today. We have four parts to it. We have an intercollegiate part, we have an intramural part, a part, and a physical education part. Our inter part has 26 teams, 950 athletes, which is probably about 400 more than most intercollegiate teams have. 10 female, 15 male sports, and 1 co-ed. Sports, you can see there, they're quite robust, and we have ample opportunity for cadets to compete and all injure themselves. Our physical education curriculum is also pretty robust. You can see we have boxing, our female will take self-defense class, we have combatives. You can see here we have cadets negotiating a wall, but this is, again, this physical education program is probably unrivaled at other institutions other than the Air Force Academy and Naval Academy. As far as our injury surveillance goes, as you would expect, boxing, combatives, rugby, football, wrestling, hockey, and lacrosse all have the highest concussion injury rates. Through our education process for the last 5 years or so, we actually started seeing our concussions to let off a little bit and actually decrease in some sports due to the way we manage that particular activity, through changes due to some of the statistics that we accumulated over a long period of time. Been mentioned before, our female cadets do take longer to return following a concussion. Approximately 92% of our concussions resolve within that time period that's been talked about today, usually around 7 days, but we found between 5 and 10 days, most of our concussions have resolved. Game carry a significantly higher risk of concussion than practices. That's fairly common, even though our athletes spend a much higher proportion of their time practicing than in games. So, and I'm going to qualify that also in saying that we've gotten a lot smarter in how we practice with a lot of our sports too. Really, when we talk about managing concussions, the athletic trainers are really on the front line. We're the ones that practice every day. We're out there on the fields. We actually get to know the athletes. We know their personalities. And so when something does happen and an athlete comes off the field or we're examining them and we can tell that maybe just something isn't right. And so that helps us a lot when we're dealing with this issue that isn't always straightforward. Physicians are there and they're great, and I know we have a lot of them in the room, but they're not usually there at every practice. And typically they roll in about 20 minutes after a practice had ended or just on game day. Management really begins in the season with a pre-participation physical, where we go through the entire history and try to identify things in history that may crop up during their participation. It's imperative that we have an emergency action plan in place. So if something bad does happen, it could be wishing or another problem. We have that plan in place for the medical personnel to evacuate and transport that patient on to a higher level of care. We do impact testing on all of our athletes. That is a costly endeavor when you're talking about 950 athletes. The rest of our cadets at West Point not get tested, and we're trying to look at that and address that issue right now. We do baseline testing, balance testing. In the preseason, we have a team meeting where we meet with the team and we go over a lot of rules and stuff, but we concentrate on concussion management. We want to make sure our cadets know what a concussion is, what it looks like, what it feels like, all the signs and symptoms, and we really have pounded that into our cadets. We also show a video, and some of those are kind of back on cervical spine injuries. A lot of the same mechanics that go into a cervical spine injury, a catastrophic spine injury is also possible, but we also show that because we know that a cervical spine injury usually is a blow to the crown of the head, and again, that can cause a concussion also. We use posters in our locker rooms. We also put them in the referee's room. So officials that are refereeing a game also have that in their mind as the last thing they leave their locker room to go out on the field to referee a game. At the end of the meeting, we actually have them sign acknowledgement forms saying, I understand that I've been educated in concussions. I understand what it looks like. And if I see a teammate, I'll make sure that they get help too. When I'm out there on the field or on a practice field, what have you, the first thing I do is look at the airway, breathing, circulation, and then I look to exclude a cervical spine injury. You get them off the field. As Dr. Rook said, the side isn't always the best place to look at an athlete. There's team coming up to see what's on. Coaches are in your ear. We got fans. We sometimes even have parents. So we try to get them into a locker room or to a quiet space where our exam is a lot more effective. Again, no same-day return if we think they're concussed. And then we do a serial exam point on to make sure that they're not degrading as far as their level of consciousness and so on. And then there's a referral to a physician. Some of the tools that can be used to look at or do a sideline assessment, the SCU is pretty well documented out there. More recently, the NFL has their own sideline assessment tool also. And again, either one of them can be used to perform that assessment. Balance testing, which is the balance air scoring system. You see on the top there, the individual's got his hands on his hip. He's on level ground, barefooted. On the bottom row, he's on a full pad, which makes it a little bit tougher. You can score that to see how their balance may be impaired. Really, the cornerstone of our concussion management is emotional and cognitive rest. And that is the biggest challenge in my age group, 18 to 22-year-olds, in trying to lasso them and keep them down for the count. They're very active individuals. And then a stepwise progression toward return to play. These are some of the things, and a lot of these have already been mentioned before, but I can tell you the cognitive rest thing, if you look at that side where you have iPads and iPhones and computers, that's a challenge for us to get our athletes and our cadets to kind of dampen down a little bit. That is a huge thing with that age group. And then academic accommodation, which we've really focused on the last couple of years because of the nature of West Point, where cadets normally take between 20 and 22 hours per semester. So if they miss a couple days, like we've talked previously, some of the speakers, really put them in a hole, particularly if they're marginal students to begin with. Not that we have a lot of marginal students at West Point, but these are some of the things that we do at West Point. Computer input of a concussion, email is sent to an academic advisor, sent to every instructor that individual has, and lets them know what the plan ahead is for that particular athlete with very specific instructions, just like you see here, and some that have been mentioned previously. The return to play that we actually use, this is kind of a generic one. We actually use a heart rate monitor throughout the return to play, which gives us a little bit more information and dials in what we're trying to look at. But this is from Zurich in 2009. It may be updated, I'm not sure, here in the next couple months when the new guidelines come out. We have a head management team at West Point, and it is comprised of physicians, psychiatrists. We do have a psychologist on there. I omitted her name. We have our counseling office. We have athletic trainers, our safety office, our dean's office, and then we have actually our prep school. It helps out there. And we're really charged with injury surveillance. We identify concussion risk. We make recommendations to a three-star general who, at the end of the day, can accept our recommendations or ignore them. And then one of the bigger pieces is we conduct faculty education. Our faculty changes out every couple of years, and so we do extensive education with them. Thank you.
Captain Sal?
Everyone, I'm a neurologist and I direct the TBI programs for Navy medicine. So I'm not going to have any slides this morning. I'm just going to go ahead and give you an overview of what the Navy and the Marine Corps are doing. For those of you who don't know, the Navy provides the corpsmen and the physicians that support the Marine Corps operations worldwide. And so speaking on behalf of both organizations this morning. We'll start by just giving you a little bit of an overview of what the have in DoD, and we work very closely with the Army and the Air Force as well as the other component organizations such as the Defense Centers of Excellence for Psychological Health and TBI and the Defense and Veterans Brain Injury Center and other groups who have an equity stake, such as Central Command, for example, where they control the ground forces in Afghanistan. First, DoD has an official definition of concussion, which all of the services use. So one of the things that we realized a few back was that there was no standard definition that we were using to define what actually constitutes a concussion. And so definition is that one, you've had to have a head injury event of some sort or an event that could have caused a concussion, and you have to have one of three criteria being met as well. And those criteria are you have an alteration of consciousness, a loss of consciousness, or post-traumatic amnesia. And there's specific set maximum times for any of those other three events that you would have had. And our approach to concussion, we looked at overall numbers since 2000, and the numbers you've probably seen in the press are over 230-some thousand concussions. But not often distinguished that most of those concussions do not occur on the battlefield. Those are actually concussions within the entire DoD network affecting military personnel. They're pulled from our ICD-9 coding. But of those numbers, 84% actually are from garrison or non-deployed settings. So that means training accidents, sports injuries, recreational activities that can cause concussion. So those are the primary causes. And then, of course, Academy, sort of most of it is sports and training, similar to what happens at West Point and at the Air Force Academy. So when we see numbers, only 16% actually occur on the battlefield. And so that's an important thing to recognize this distinction. However, the approach is essentially such that we need to have everything standardized. And so the Army and the Navy and Marine Corps right now are working on a policy that will cover our entire healthcare system so that we take the same approach to concussion in the garrison or non-deployed setting as we do on the combat in combat in Afghanistan. And that approach really is making sure that the diagnosis is given up front. And so we've emphasized training as one of the key priorities. And so for the Marine Corps, we are training all of our medical personnel on how to do the concussion evaluation. And what we use is something called the Military Acute Concussion Evaluation, which is based upon the NFL Standard Assessment of Concussion, or the SAC. And so the MACE has the history questions asking sort of what happened. And Dr. Goldman, who will be speaking after me, and our colleagues in the DoD have been instrumental in making sure that training and everything is set up to become easily understandable. So we do the history, and then we have the cognitive test, which is essentially after the assessment of concussion in the NFL, which has a lot of word lists for memory, and it's very heavily memory dependent. We have a neurological examination. Now we have a balance test measure as well. And then there's a symptom score asking if people have headaches, things like that. Because you can have blast-associated headache in the absence of concussion, or blast-associated dizziness in the absence of meeting criteria for concussion. It also has strict guidelines as to what to do. I mean, the main approach is rest and education as to what expectations to have during the course of recovery. We have concussion centers in Afghanistan. The Navy staffs two, and one at Camp Leatherneck, which is the Marine Corps base, and one at Kandahar. And from the numbers that we've seen from Leatherneck with the Marines, they also treat service members from other countries as well as other services. Since August 2010, when they first stood up an interdisciplinary program which has mental health, has neuropsychological testing, has physicians, OT, occupational therapy, physical therapy, we've seen over 1,000 concussions. 98% of the people who were seen at this particular clinic returned to duty after an average of 10 days. And so we believe our return to duty rate, which is based on sort of this similar, a graded approach, meaning that you're symptom-free after exercise and that you've cognitively recovered as far as we can tell, is showing that military combat concussion, you can return to duty similar as that in the sports world where you return to play. It's also very active in treatment programs in the U.S. for people, service members with persistent symptoms after the return. We work closely with the National Intrepid Center of Excellence, which is a TBI center on the Bethesda campus, and we also have concussion centers at our two main Marine Corps bases and other concussion programs throughout our military healthcare network. Last, we're also involved in the research endeavor, looking at the utility of pre- and post-deployment neurocognitive testing. We also have funded development of this thing, which is we call the DANA, the Defense Automated Neurobehavioral Assessment. It's a handheld computer with a bunch of neurocognitive tests, so similar to IMPACT, which is used by the NFL, the NHL, and many sports teams. The NAM, which is the Automated Neurocognitive Assessment Metrics, which the DoD uses as its standardized test. And so currently we're testing this in Afghanistan and with sports teams to see how useful some of the tests they have, for example, like simple reaction time, are compared to the MACE, for example. So I'll give you this morning with just a little bit about the Academies, which is that we don't have blanket neurocognitive testing for the sports teams, but we have worked with the data over there, and they have a sort of education program. They take the cadets out, the midshipmen out, similar to the cadets at the West Point, and there's a graded return to duty. And so overall, the Navy and the Marine Corps approach is that we take concussion as a very serious problem. We're glad that groups like the IM and Congress and our senior leaders have shown a spotlight on it, because it makes my job and Sid's job actually easier, since public awareness has now risen. And we're very invested, and we're now also looking at longer-term outcomes after return to duty after a concussion to ensure that we are able to safely return people to full jobs, sort of their full jobs in the military.
Thank you.
Major Goldman.
Good morning. It's an honor to be here. My name is Major Sarah Goldman, and I'm at the Office of the Surgeon General. Kind of my purpose is to kind of give high-level strategic overview. We've kind of talked a little bit about the tactical implementation of concussion care, but I'm here to give more of a strategic level. So next slide. So represents the proportion of TBIs since 2000 to 2012. And you can see here on this slide that the overall majority is mild, approximately 76% are mild TBI, and then you can see here the distribution of the services, and the majority of TBIs are certainly in the Army. Just kind of shows it with mild, moderate, and severe. Again, this is the mild, and you can kind of see this steady peak. We get a lot of questions about this slide from folks from Congress, and a lot of questions. They're like, what's going on with this really sharp increase, kind of about in 2006, 2008. In 2006, the military acute concussion evaluation was made. In 2008, that is when the post-deployment health assessment and health reassessment enforcement was mandated. So there's significantly policy changes, significant screening tools that were implemented about during this time. So we don't think that necessarily there were more during this period of time. It's just that we've been able to identify them through policy and screen measures a little bit better. As Captain Sal mentioned, 84% of all DoD TBIs from 2000 to 2011 occurred in garrison back here. And so, we redeploy out of Afghanistan, TBI is going to remain a major military concern. You can kind of see the distribution over time. It's not 84% every year, but it's certainly averaged over a 10-year period. So, for example, during the past 3 years, at least in the Army, it's probably closer to 60 in the late 50%. So, if anyone's interested in specific data, I can get that later. From a overarching strategic standpoint, this is really the Army's enterprise management strategy: educate, train, treat, and track. When we think about the foundation of it, it's research. How do we know what to do? How do we know what protocols we're supposed to implement? How do we know what clinical care guidance is best? And it's this. I have a slide later, but really, the military investment has been over $700 million in TBI research since 2007, and I'll detail that in a bit. That research that informs policy and guidance, and we certainly have new policies. Probably one of the most important ones here is the policy in 2010 that mandates a medical evaluation, mandates a minimum 24 hours downtime following any potentially concussive event in Afghanistan. It's a commander's policy. It takes that person out of it. It allows them to just follow the policy, and they don't have to raise their hand and say, hey, I think I'm having some problems. It really helps reduce the stigma. We're very proud of the 2009 VA DoD CPGs. They were actually recently read in a July 2011 edition of Brain Injury as the highest CPG out of about 8 that they evaluated. So some very strong guidance. I know this is a youth concussion area, but it is primarily for adults, obviously, so there's still a youth gap, I think, with respect to policy. Our overarching strategy is education, and the Vice Chief of Staff of the Army made education the top priority, the overarching line of effort for a particular reason. And then train, treat, and track is the core strategy, but we do this with many partners, many stakeholders that are depicted on both sides of this slide. This is just kind of a snapshot of Army TBI care capabilities. We stratify our programs based on the needs of the patient. So Category 1 programs, such as our big programs at Fort Lewis and San Antonio, at formerly Walter Reed here in D.C., would care for the complete spectrum, mild, moderate, severe, and penetrating TBI, where our small sites, like at a Fort Huachuca, Fort Irwin, they're pretty much going to only be able to care for mild outpatient folks. But we are to refer, use community resources when needed. We have significant telehealth capability, which is that little square right there, and as you can see, it permeates throughout our system. We really need to make sure that we're serving the Reserve and Guard and other populations that may not be able to come into a facility. So we've invested quite a bit in telehealth capability. I have a slide showing our concussion care centers in Afghanistan, but we have an additional 5 that the Army runs in conjunction with the 2 Navy care centers that Captain Sal mentioned previously. We have mandated TBI training across the Army, not just for medical providers, but for all leaders and soldiers. Everything is centrally located on Army Training Network. We have policies, and we have a host of PowerPoint presentations and videos that were actually approved by all of the services. So it's one-stop shopping. So if someone gets information from, for example, AMED Center and School in San Antonio, it's going to be the exact same information that reservist in Idaho gets. So standardization of training, standardization of policy across a massive organization is absolutely essential. This slide just essentially depicts the research approach to TBI. This is a breakdown of that $700 million since 2007 in TBI research. I know it's a little dark in the room, but I'll just kind of go through it. We have basic science studies, really that kind of stratify the entire scope. We have studies related to TBI, concussion, prevention, education, and training. We have some that are dealing with dosimetry and possible concussions from a blast. Screening, we're looking to advance guidelines for screening, looking at many innovative technologies, EEG, eye tracking, all different types of impairment assessments, and assessments really looking at CT, MRI, neuroimaging, quite a bit of research investment going on there. Certainly treatment, not only pharmacological interventions, also acupuncture and those types of alternative medicine interventions. Really nothing's off the table when it comes to treatment. We just want to identify what's the most effective way to improve concussion treatment. We certainly need much more scientific evidence. I'm sure you all know the level of scientific evidence is in education. We need to do much better than that, and we're very aggressively researching that. Certainly recovery and reset, we're looking at return to duty standards, evaluation. We still do not have that objective test for TBI. We do have that objective test when we know it's safe for them to return to duty. It's still mostly symptom-based, mostly a clinical exam, but we are certainly being very aggressive to try to find something more objective. Here are a couple of research examples. We've got over 40 studies in biomarkers. We are looking forward to one day when there's either a blood test or a saliva test or something like that that's going to be able to definitively diagnose. We have other pilot studies that, for example, the NFL is doing work with this as well, have a 6-axis accelerometer, the helmet, so we're able to kind of model and determine what happens during potentially concussive events. This is actually at the bottom here. It's actually this small device, the DARPA blast gauge. That's a dosimeter that's able to measure blast overpressure. So you just kind of push the button and it lights up. And I have a few that I can show afterwards. Certainly, CTE has been a significant concern, and there are many research studies that are looking at long-term neurodegenerative effects of multiple concussions over time. Heard in the news about the Army has a formal partnership with the National Football League. We launched this at West Point in August of this past year. And it's looking at getting players and soldiers together to really discuss BI, looking at reducing the stigma related to seeking care. And just kind of as a heads up, I don't want to certainly spill the beans, but there's going to be a major announcement the second week of March. So look forward to some additional media activity related to the NFL. I will stop there, and I very much look forward to your questions and for the opportunity to present to you today.
Thank you. We'll begin with committee questions from the committee, and as we did previously, if you would just go to the microphone, and we'll take you in order.
Morning, Tracy Coulson, Michigan State University. Part of our statement of tasks that the committee is charged to do is to look at concussions among military dependents. Can you describe if these military dependents are at an increased risk for concussion compared to the general population, and if they recover differently compared to the general population, and why this is a focus for military?
So there has not been a specific study with respect to military dependents, and we have no reason to believe that there'd be an additional risk with regard to the population. I mean, certainly it would depend on what types of extracurricular activities they're involved in. I mean, they're certainly not out jumping out of perfectly good airplanes with their spouses who are injured in training accidents. And I don't mean to be facetious that way, but I think it would certainly be on an individual basis. But there has not been any population-based studies, to my knowledge, looking at different risks for military dependents. And I would have no reason to believe it would be separate from the population. But I'll defer to Captain Sal.
I concur. I think that we're seeing, obviously, the dependent concussion risk is youth sports and youth activities. So I don't think that would be any different. DoD schools don't teach military maneuvering or combatives or how to do boxing as routine. So I think that the numbers will probably reflect that seen in the civilian world.
Quickly, wanted to mention that there are numerous educational initiatives to dependents, to spouses, and to kids on DoD installations. So certainly the educational initiatives that all the services are working on, there is quite a bit of an outreach to dependents and spouses. So.
University of Nebraska. What about reactions or these of families' responses to a spouse with a head injury, because of things like changes in temperament, irritability, and so on?
Absolutely. That's one thing that the DoD is certainly very concerned about. And in terms of concussion evaluations, our recommended approach in our TBI center specifically are that the spouse or other family members accompany the service member who has persistent symptoms to their medical appointments, so that we can actually determine sort of what their perception of what is going on actually is. In terms of the overall treatment offered, recommendations, it's a holistic approach in terms of sort of the spouse may need to watch for X, Y, or Z. You need to let the doctor know and be sort of invested in the care of the service member spouse.
Just to add, while there maybe not be a lot of formal research studies, there are certainly a tremendous amount of resources for family members. For example, the Defense and Veterans Brain Injury Center has published the Family Caregiver Guide. They also distribute, it's a children's book, and I can't remember the title off the top of my head, that's very nicely illustrated for very young children to be able to understand and to be able to speak with that their parent who has experienced the TBI. So that's actually a very innovative resource that the Defense and Veterans Brain Injury Center has put together, and all of the services use those resources in our military treatment facilities and make it available Army or service-wide.
May hold you just a moment. Dr. Margulies apparently does have a question via the phone. Susan? Yeah, can.
Okay, great. So Susan Margulies, University of Pennsylvania. Sorry to be logging in as a disembodied voice. Get an echo, but can you hear me?
Yeah.
Okay, good. So my question has to do with the activities on base that are most frequently associated with concussions. What are those? Many different sports were mentioned, many different training activities. Are some that are associated with more frequent occurrence of concussion?
So I can speak for the Navy and the Marine Corps because we looked at the data to see what the actual cause of injury was. The best numbers are actually from the last year because that's when the E-codes for actual sort of mechanism of injury were actually better defined for the purposes of coding through ICD-9. And so a snapshot that we saw, it turned out that falls were the number one cause of injury. Now, falls can be accompanied by can be really falling downstairs, falling off your bicycle or your motorcycle, falling because you were hit on the playing field. So I think that when we look at specific events, I would say that it's sports and motor vehicles typically are the highest risk for concussions. Training, obviously, if you're doing combatives, which is practicing hand-to-hand combat, that of course also carries a risk, although there are many safety procedures in place.
Is gender breakdown?
The numbers that we looked at, it's primarily male occurrence.
Thank you.
Other questions, Dr. Margulies?
No.
All right, thank you. Nia?
Two things. Could you comment on the access to health care a military dependent has? And one question is, we were also charged to speak about recruits with a history of concussions. So can you tell me how you deal with recruits who have a history of multiple concussions?
So the access to healthcare, sort of our healthcare network has specific guidelines that we have to meet, that we have to see people acutely with an injury within a certain number of hours or days, depending on the severity of the injury, whether they come in through a regular appointment system, the emergency room, or what the access to our system is. And referral for specialty care, TRICARE, if it's done outside the hospital or even within, you have a certain number of days you actually have to be able to get in to see your specialist. So access to care, sort of take care of our dependents, is one of our primary missions. I mean, the military healthcare system is to take care of the active duty service member, their family, which are the dependents, as well as the retirees and their families. So we really strive to ensure that we offer world-class health care in our system. In terms of the recruit question, that's something that we've all talked about. We obviously are aware of the studies which have been done by, or being informed by a civilian sports world about sort of the total number of concussions, how quickly you recover from them. And at this time, we don't feel that we've seen the evidence which would suggest that we would need to exclude someone because they had, 5 or 6 concussions prior to joining the military. We do, however, is that our policy, and will soon be mirrored with our garrison type of policy, is have one concussion in theater after you're symptom-free with exertion and you feel you're recovered, your physicians feel you're recovered, you're returned to duty. If you have that second concussion within a 12-month period, you have to be symptom-free, and then you have to wait another 7 days before you can work outside in a combat type of patrol setting. And if you happen to be so lucky as to get a third concussion in 12 months, and those don't all have to occur on the battlefield. I mean, you could have had a concussion in training or from sports prior to deployment in that 12-month period, you have to go see the theater neurologist for a comprehensive evaluation, and he or she can then determine if you're to return to full duty, if you're going to return to duty but you're not able to go outside your combat outpost, or whether you get sent home because you're not recovering from your symptoms. FOR has taken an even stricter view towards the policy, find that 2 loss of consciousness concussions in the 12-month period mandate that you have to go see the theater neurologist, and even if they clear you to return to full combat duty, they will keep you inside the wire, as we say, sort of keep you on the post working so you're not exposed to further chances of being concussed outside.
I would just add to the recruit question that there's certainly no magic nerve concussions that would disqualify anybody, and there's no policies saying that. It really is about their function. How was that person doing at that time? I had 4 concussions before I came in the military, and another one after the military. So again, it's how are they able to recover? What is their functional status at that time? And do they meet the basic health criteria to either enter into military service or not? And it's not just for concussion; it's for any physical condition. So.
Vishwanath, Harvard University. I have 2 questions, Major Goldman. You said education is one of the key strategies. One, how do you know that the education is working? Is it evidence-based to evaluate it? Number 2, what does it actually have? Is it just fact-based education or something else?
Good question. We do offer CMEs for education, but I think a good example of that is really looking at educational outcomes. We have just started to do that more with our TBI for deploying providers course, for example. So we have everybody remote, and we have questions that come up, and we're able to. They have a pre-test, a post-test, and we're able to ask them questions as it goes along with that technology. But we really believe that the educational experience should be multimodal. Certainly, we do the standardized training decks online to be able to meet the needs of a geographically dispersed population. For example, for this TBI for deploying providers course, it's not just all death by PowerPoint and videos. We have many hands-on experience of actually practicing the MACE, getting peer feedback. For example, we have trauma lanes that we do. It's actually a half day of trauma lanes that we do where they actually go through being each of the stages. So we are really pushing for a multimodal hands-on experience for those in-person courses. But I think the challenge with distance education, especially as we're tightening our belts more and more down the road, and getting those health education outcomes is absolutely an area where I think we need to improve. We just have very basic outcomes at this time, but great question. And real quick, while I have the mic, I just wanted to mention there was a driving question asked in the last course. And in addition to all the policies that we've talked about today, there are formal clinical recommendations on the DivBIC website for driving, return driving, neuroendocrine dysfunction, vision, vestibular rehabilitation. This year, we're going to publish formal clinical recommendations for graded return to activity. It's going to be the Zurich guidelines on steroids. It's fantastic. We're going to have a clinical recommendation for sleep in TBI, for neuroimaging in TBI. So I think the DoD has certainly led with respect to policy and clinical guidance development. So look for those things to come down in 2013.
The only thing I'll add on the education piece is that we, similar to the Army, have a mandate for all of our healthcare providers to have basic TBI education. They have awareness, know what needs to be done. And in terms of our formal training for deployment, we do a course where we do face-to-face with the corpsmen and the medical officers, where we teach them sort of what is concussion, how to manage concussion, what is the MACE, how do you properly do the MACE. We have an observed period where they do practice. They have case scenarios to go through, and we also go through the clinical practice algorithms of what the medic or corpsman needs to do, as well as what the provider does, when to image, when to call for help. We do a pre and post course survey with questions to assess knowledge and to determine how things have improved, and then we do a 6-month follow-up theater to say, have you used the training that we gave you? What have you thought about it?
Hi, the University of Pittsburgh. Thanks for the driving feedback. But I was coming to ask about that. What kind of screening do you do for previous concussions before coming into the service? And do you ever rule somebody out because of a history of multiple concussions?
So when folks enter the service, they're required to complete a full physical. And part of that physical includes the neurological exam. I'll let Kat and Sal speak kind of to the more neurology portion of it. But there's not a certain number of concussions. It really is based on their function and their ability to perform the required tasks. Certainly someone like myself who's had many concussions but doesn't have any persistent symptoms would be able to enter into military service. But those who have symptoms, persistent symptoms and disruption in function that may not be suitable for military service, then the neurologist or the physician would make that call and let Kat and Sal speak specifically to the neurology portion.
So we sort of overall do not actually do any screening for total number of concussions lifetime. And really it's functional based. We don't even do a sort of entry neurocognitive assessment, as you have talked about wanting to do as a mechanism for screening. Basically, it's really sort of what medical conditions have you had. If they are what we consider waiverable, mean that they're not going to permanently disable you down the road. So certain conditions, like if you happen to have headaches, might be okay. Certain conditions, if you've had cancer, for example, is probably not okay to join the military service. And so it's really, can you perform the tasks that are assigned to you? And we'll also take an entry exam as to overall abilities in terms of just we learned at school. And so that's partly what's used to assign you later on after you do your basic training to what specialty you'll be doing within the military.
Okay, thank you.
Other questions from any of the committee members? I will thank this panel again very much for your contributions. The open session of the committee will resume at 1 p.m. Morgan wanted me to remind people of the cafeteria arrangements. Okay, the cafeteria in the Institute building is open to the public, and it's in the basement. And as you leave here, you go left, and pretty much anytime you see stairways going down, go down. And you will either be right at the cafeteria or somebody will direct you. And good food.